Welcome back to the deep dive. Ever heard of a heart murmur or maybe mitral valve prolapse?
Yeah, MVP. It sounds a bit complicated, but it's actually quite common.
Exactly. And today we're going to break it down. We've got some really focused revision notes here. And the plan is to pull out the absolute must-know info on MVP.
Make it clear, easy to remember, sort of exam ready.
Perfect.
Yeah.
So let's start right at the beginning. What actually is mitral valve prolapse?
Okay, so fundamentally, you've got the mitral valve, right? Between the left atrium and left ventricle.
The main pumping chamber, yeah.
Right. With MVP, the leaflets of that valve, the little flaps, they abnormally bulge or, well, prolapse upwards into the left atrium. And this happens during systole. That's when the heart contracts to push blood out.
So instead of sealing tight, they sort of billow backwards a bit. Why does that happen?
It's usually down to the structure of the valve apparatus itself. Think leaflets that are maybe a bit elongated, a bit floppy.
Okay.
And the chordae tendineae, those tiny strings holding the leaflets, they might be a bit weak or stretched too.
Ah, okay. Like the anchoring ropes are a bit loose.
Yeah.
Now, does this always cause a problem? Is it serious?
That's a key point. Often, no. A lot of people with MVP have absolutely no symptoms. They might never even know they have it.
Right.
But it can potentially lead to complications, things like mitral regurgitation, that's backward blood flow through the valve.
It's a Mickey valve.
Exactly. Or a slightly higher risk of infective endocarditis, which is a heart infection.
Yeah.
And very, very rarely sudden cardiac death. But again, those serious ones are uncommon.
Uncommon, but good to be aware of. So how do doctors pin this down? How is it diagnosed for sure?
The absolute cornerstone is the echocardiogram. An echo, it's basically an ultrasound of the heart.
Right.
It lets doctors actually see the valve leaflets moving and confirm if they prolapse more than 2 millimeters back into the atrium during systole. They also look for any thickening.
So the echo is the definitive test.
Got it. Now,
Yeah.
thinking about causes the etiology, where does MVP come from? Often we don't know the exact cause. It seems to be a bit of a mix, maybe some genetic factors, possibly environmental influences too. We often see something called myxomatous degeneration. That's where the valve tissue itself is sort of thickened, redundant, a bit spongy or floppy.
Okay.
It's very common in MVP, but why it happens isn't totally clear.
Interesting. And the notes mention links to specific conditions, don't they?
Yes, absolutely. And this is quite important. MVP pops up more often in certain connective tissue disorders, things that affect the body's scaffolding, basically.
Like Marfan's.
Exactly. Like Marfan syndrome, it's found in maybe 28% of people with Marfan's. Also, Ehlers-Danlos syndrome, that's about 6%.
Wow.
And others too, like osteogenesis imperfecta, pseudoxanthoma elasticum, even adult polycystic kidney disease. It highlights how connective tissue health is key for the valve.
That makes sense. A general weakness showing up in the valve. And you mentioned genetics more directly.
Definitely. It can run in families. Often it looks like an autosomal dominant pattern, meaning you only need one copy of the altered gene. But and this is important, the expression varies hugely. One person might have clear MVP, another relative with the same gene might have almost nothing show up.
Variable penetrance, right.
Yeah.
So who's more likely to get MVP? Any specific risk factors we should know?
Yeah, there are a few. A family history, as we just discussed, is a big one.
Makes sense.
Those connective tissue disorders are risk factors too. Interestingly, it's more common in females.
Oh, really?
Yes. And the peak age for diagnosis tends to be between the 20s and 50s. Also, sometimes a thin body type, what doctors call a thin habitus, seems to be associated.
Okay, that's useful. Family history, female, certain ages, thin build, connective tissue issues.
Got it. So functionally, pathophysiology, what's happening inside the heart with MVP.
Well, that bulging we talked about,
Right.
It means the valve might not close completely during systole.
Right.
And if it doesn't close completely, blood can leak backward from the ventricle into the atrium. That's the mitral regurgitation, or the MAR.
The leaky valve again. Precisely. And over time, that extra stress on the floppy leaflets and the stretched chordae can actually cause more wear and tear, more degenerative changes.
So it can potentially worsen over time.
Yeah.
Now, if a doctor hears a click sound when listening to the heart, could it be something else besides MVP? What about differential diagnosis?
Good question. Yes, that mid-systolic click is classic for MVP, but it's not exclusive.
Okay.
You could hear a similar sound if the leaflets or chordae are just a bit redundant or floppy without actually prolapsing, or it could be something else entirely, like bicuspid aortic stenosis, maybe an atrial myxoma that's a rare heart tumor pericarditis, or even just MR from another cause.
So the click is a clue, but not the whole story. Needs that echo to confirm.
Exactly.
How common is MVP overall? What's the epidemiology look like?
In the UK, estimates are around 2 to 3% of people, so not insignificant.
Yeah, quite a few people.
And again, more common in females. In the US and Europe, that myxomatous degeneration we mentioned is considered the most common underlying cause. And it's worth remembering. MVP itself is a risk factor for developing significant MR, potentially leading to heart failure, arrhythmias, and that risk of endocarditis.
Okay, so let's talk presentation. What would someone actually experience, or what would a doctor find?
Okay, clinically. The classic thing to listen for is that mid-systolic click, sometimes followed by a late systolic murmur if there's regurgitation.
And you mentioned something earlier. These sounds can change.
Yes, that's a key feature. Their timing changes depending on things that affect preload, how much blood is filling the heart, and afterload, the resistance the heart pumps against. It's quite dynamic.
Interesting. What about symptoms the person might feel?
Well, the big takeaway is most people feel nothing. They're asymptomatic.
That's reassuring.
Definitely. But if symptoms occur, they can include palpitations like racing or skip beats, atypical chest pain, often sharp, not like classic angina.
Okay.
Also, fatigue, maybe shortness of breath with activity, sometimes dizziness or lightheadedness, and interestingly, sometimes anxiety or even panic attacks.
Anxiety. That's fascinating. Is that linked to the inherited form you mentioned?
It can be, yeah. Particularly in inherited MVP, you sometimes see signs of autonomic dysfunction problems with the nervous system controlling heart rate, blood pressure. So that might manifest as anxiety, panic, palpitations, fainting or near fainting, even some neuropsychiatric stuff. And also, look out for associated physical signs, sometimes low body weight, pectus excavatum, joint hypermobility, arm span greater than height. Those Marfanoid features.
It's like a whole picture, sounds, symptoms, physical signs. Okay, investigations.
Yeah.
If MVP is suspected, what tests get ordered?
Echo, echo, echo. Echocardiogram is number one. It shows the structure, the function, confirms that prolapse the 2 mm bit.
Right, the gold standard.
Definitely. They use specific views, like long-axis parasternal or apical views on the 2D imaging. Sometimes a stress echo might be done too.
To see how it behaves under stress.
Exactly. See how the valve and heart respond when working harder.
What about an ECG, the heart tracing?
ECG is often normal in MVP, but it's still useful, especially if the patient has palpitations or dizziness, to check for arrhythmias or conduction issues. You might see some non-specific ST or T wave changes sometimes.
Okay, and if palpitations are a big feature?
Then you'd think about longer-term monitoring, like a Holter monitor for 24 or 48 hours, or maybe an ambulatory event monitor if symptoms are less frequent, just to catch any underlying rhythm problems.
Makes sense. Maybe an exercise test, too.
Yeah, that can be useful to objectively assess exercise tolerance, especially if someone's reporting shortness of breath or fatigue on exertion and you're not sure how limited they are.
So a suite of tests, but the echo really nails the diagnosis.
Absolutely. A standard transthoracic echo, TTE, usually confirms it. Sometimes a transesophageal echo, or TOE, might be used. It's more sensitive, especially for certain parts of the valve. And 3D TOE is great for mapping out lesions before surgery.
Right. ECG and chest x-ray, usually normal unless there's significant leakage.
Correct.
Okay, management. Someone's diagnosed with MVP. What happens next, based on UK guidelines?
For most people, if they're asymptomatic, it's mainly about reassurance.
Good news for them.
Yeah. Generally, no specific treatment needed. Just regular checkups, clinical exam, maybe an echo every 3 to 5 years to keep an eye on things.
Any lifestyle advice?
Sensible stuff, really. Maybe avoid excessive stimulants like caffeine if they cause palpitations. Manage stress. Pretty standard, healthy lifestyle advice.
What if they do have symptoms?
Yeah.
For medications used?
Yes. If someone's bothered by palpitations, anxiety, or that atypical chest pain, beta blockers are often the first port of call. They can help calm things down.
Okay. And antibiotics before procedures, is that still a thing?
Less so now. Antibiotic prophylaxis for endocarditis prevention is really only for specific high-risk individuals undergoing certain procedures like GI or GU procedures if there's an active infection site, not routine anymore.
Right, much more targeted. When does surgery come into the picture?
Surgery, specifically mitral valve repair, is considered mainly for people who develop severe mitral regurgitation.
So significant leakage.
Exactly, especially if they also have symptoms, or if the heart is starting to enlarge, or its pumping function is reducing, or they develop atrial fibrillation or pulmonary hypertension.
And repair is preferred over replacing the valve.
Yes, generally. Mitral valve repair usually has better long-term survival and outcomes compared to replacement. There are newer keyhole techniques being explored, like percutaneous leaflet repair, but right now the guidelines suggest there isn't quite enough evidence to recommend those routinely over traditional repair.
So surgery is for the more severe end of the spectrum. How's the overall outlook, the prognosis?
Generally, really good. The prognosis for most people with MVP is excellent. It's usually a benign condition. They live normal lives.
It's very reassuring.
It is. But as we've said, a small minority can develop complications over time that significant MR, endocarditis, arrhythmias, or very rarely sudden death.
And because of the genetic link, screening family members is worth considering.
Yes, particularly for first-degree relatives, parents, siblings, children, especially if the person diagnosed has significant MVP or complications. An echo screen for them is often recommended.
Good practical advice. Okay, let's wrap this up. So, mitral valve prolapse, common, involves the mitral valve leaflets bulging back, often asymptomatic.
Caused by structural issues, often myxomatous degeneration, sometimes linked to connective tissue disorders or genetics.
Diagnosis relies heavily on echocardiogram showing that 2 mm prolapse.
Management is often just reassurance and monitoring. Beta blockers for symptoms, surgery reserved for severe regurgitation with complications.
And the prognosis is generally excellent, but complications can occur in a minority.
Exactly. Awareness and appropriate follow-up are key.
Fantastic summary. And remember, for more detailed information and resources, especially if you're prepping for exams, do check out passthemsra.com and also freemsra.com.
Great resources there.
Thanks for joining us on this deep dive into MVP.